We've got kind of a longer presentation than normal, so I think we'll go ahead and get started. I know some people are still joining on here, and we'll do a little bit of housekeeping as we're going. So welcome to Screening and Testing for Dental Sleep Medicine from us here at Dental Sleep Solutions in DS3. That's who we are. As you're looking at your screen, I'm the guy on the left. Rich is the guy on the right. And we've been doing this a long time. I think between us, what, Rich, about 30 years if you add the two together?
Who's counting anymore?
I forget. I'm getting too old, so I might forget where we were anyway. But we've been doing this a long time. We've done thousands of devices. A lot of you have heard our other webinars. And this is part of the series that Keller Lab is helping to sponsor and given the CE for this as well. So we really appreciate Keller joining in on us to help educate dentists across the country. We've been using them for many, many years. They do a lot of our sleep devices. One of my favorite ones I always tout is I wear this one most nights myself, the Clear Dream. It's probably the best value of all dental devices out there because it's a great dental device, which there's a lot of great dental devices in the country, but this is one of the better ones, and it's certainly at the best value at $305. So we will be talking about devices. You see today we're talking about 2 of the 4 pillars of dental sleep, and we'll be going into detail on those in the future. And of course, you all know Keller for the NTIs too. We still use these in our practice to deprogram muscles to help people with TMD issues in conjunction with their sleep concerns. And I'll just finish this, Rich, if you don't mind. I'll talk about KKGI. I've been using a cone beam CBCT for a while in my practice now, and that is our next webinar that we're doing in July, and we'll be talking about how we're using this in our practices, how it's changing things, and KKGI, the instrumentarium OP300 is the unit I have, and we'll be talking a lot about CBCT and how you use it in dental sleep medicine.
Excellent. The only thing I would add to that, Guy, is I know some of you use Keller for other things, and if you're just getting into sleep, we would highly recommend that you give them a try for the dental sleep devices as well. So I think we had like 600 IQ points in the room, Guy. It only took us 6 hours to come up with this, our mission statement. We are the most trusted, innovative, and customer-focused provider of solutions in dental sleep medicine, period. So you don't have to reinvent the wheel. We just have a couple little commercials here, but that's what we do at Dental Sleep Solutions. We have a software that's a backbone for what we do, but there are a lot of things that have to work for this to work in your practice. So we've tried to put all of these things together in a package that we started this, what, 8 years ago now, Guy, and we just do this to help dentists succeed in dental sleep medicine.
Yeah, and we were at the AADSM meeting recently in Denver. I'm sure a lot of you all were there as well. And I tell you, one of the more rewarding things each year, we come back to that, and we have more and more people that are our members coming up and telling us how that we've helped them help their patients live better and longer. And that really, really personally makes us feel good. So thanks for anybody who's on here who came by and thanked us for what we do. We do a lot of courses throughout the country. You can see them listed here. And a lot of them are 2-day courses where you get a dental device made and some hands-on portion of them. Some of them are 1-day courses. And we are offering tonight, if you want to come to these courses, just type course. If you know the city, go and put the city, but just type course if you're not sure which city at least, and we will contact you, and you'll get $200 off a 2-day course and $50 off the 1-day course. So again, just type course in the city, and we'll get you registered for that. And this is we're excited about this, aren't we, Rich? This symposium that we're doing here in Florida next winter.
Yeah, absolutely. February 17, 18, save the date. We're going to have a couple of days. You get to hear people other than just Guy and myself. You recognize some of those faces there, and our old buddy John Rimmers, the grandfather of sleep, and we love to just sit around and listen to him tell stories about, oh yeah, I invented that auto pap. He makes comments like that. So yeah, we're looking forward to that. We hope to see you guys there. It'll be a great learning thing, and that really is about hands-on how to do this stuff. I know some of us were just at the Dental Academy of Dental Sleep Medicine meeting, and that's great information. I love all that stuff. That's certainly more academic. We are just more focused on hands-on and how to do things.
It's going to be
talk about tonight.
It's going to be the most pragmatic 2 days I think that anybody will ever attend. So we're excited in beautiful Clearwater Beach at the Hilton Resort. So, and if anybody hasn't tried DS3, let us know, and we will just type in free trial, and we will contact you and show you how we can help you with no pressure. I think we'll show you, if you've been doing this a long time, how to do it way, way more efficient. And if you're new to this, you certainly ought to listen to what we have to say, because we can get you going right in the right track. For a couple of weeks, we'll help you out and show you how to be efficient and profitable and enjoy dental sleep in your practice. I really like this slide because we're going to talk today about screening our patients and testing. And one of the things that comes up, Rich, when we teach these courses are, well, why are we doing this? Why aren't the physicians doing this? And we don't have a whole lot of time tonight, but I'll cut to the chase and just say, if there was a squamous cell carcinoma on the tongue there, would we be worried about that as a dentist? Is that within our wheelhouse? And I think everybody answers, of course, that's something we should be looking for. Well, my question is, when the tongue does this, when the airway does this, what medical professional should be involved in that? We should certainly agree that's somewhat in our wheelhouse, and that we should be looking for this in our practices. And a quick review of what happens if people have obstructive sleep apnea. What did everybody get today? What is it, 95%, Rich, of the people who get treated for apnea get a CPAP these days?
Not in my town, Guy. It's only 94% because I visited 500 physicians. But yeah, they get CPAP. They get a dental device. We start to cut something out, right? Sometimes we just tell them, hey, stay off your back. Positional therapy works in weight loss. So that's just, we've done webinars before, and we're going to do more about treatment options themselves. But that's just kind of an overview. And again, Guy, it's that big old tongue there. And I love that. I think you got that from your old Netter book, right? We just don't realize how big the tongue is, and then the tongue falls back on the back of the throat, and the jaw falls down and back, and we're going to grab a hold of the jaw and move it forward. So
yeah, there's really only, from the American Academy of Sleep Medicine, AADSM and AASM, first line of therapy treatments are dental devices and CPAP. So we should be involved in this, and we should recognize we don't have time to get into all this tonight, and that's not the purpose of this webinar. But I think if you understand all these things are independently associated with untreated obstructive sleep apnea, cause and effect for most things on the screen here, as we start screening our patients, we realize, wow, we're treating our patients for these other things. We're cleaning up GERD problems in their mouths as they have erosion, and we see these and all these other things in our medical history. And if we get involved in sleep apnea, Rich, I think you came up with this slide a long time ago, and I think it's probably one of the most valuable slides we have. Why do we do this? I mean, why should you be involved in this?
Yeah, well, we like to say it's the right thing to do because we're helping our patients live better, live longer, live healthier lives. And we certainly don't want to belittle what most all of you do all day, every day, which is fix teeth and make smiles prettier and get people out of pain. There's nothing wrong with that. But this is just a different level of meaningful work. You really do change people's lives in a very positive way most of the time. So we treat it because it's the right thing to do, and because we get something out of it too.
Absolutely. And the problem is, and why we should be involved, we're going to get into how to be involved in a few moments, but when you look at this picture, what I call the red pie, and you look at all the undiagnosed patients out there, and then the ones who are lucky enough to be diagnosed, just a sliver of them are really keeping their airway open most every night, most all night long. It's at least in my assessment, the most undiagnosed, untreated serious medical disorder in our country, and the medical community is trying to do their part, but there's just not enough awareness out there. I mean, it's an awareness problem. We see more and more things in the public. You're starting to see things on TV that you didn't before, and if you keep your eyes and ears open, you'll see things with that. We're here tonight to educate you as dentists, to make you aware of this, so that you can understand how to the very least, when you get off this webinar, hope that everyone that attends will recognize that they should be involved in at least screening for this. And we hope the physicians are becoming more and more aware, and we can help them. Rich, how many physicians do you meet with a month and raising their awareness, correct?
Yeah, I met with three today. So we
Yeah.
took an hour and a half, a half hour before lunch, and we went and visited three physicians. And it just takes 3 minutes sometimes, Guy. I mean, that's all I got with one guy today. And I'm convinced that he will give me referral. He was like, man, I didn't even know there was a dentist in town that did this.
Right.
More and more of our patients, we call them up and how you doing with that CPAP? And they, what CPAP? Oh, I forgot about that. Yeah. No,
Yeah.
so nobody's wearing it. So yeah, you're right. And as dentists, as we educate you, we want you to go out and increase awareness. The saying you use, Guy, all the time, a rising
All
tide floats all ships, right? Something
right.
like that. And so we need to have this attitude of abundance as we do this. So as more and more dentists do this in our communities, Guy and I used to be a little bit protective of that, but what we've learned, Guy, is what happens.
Yeah, everybody's like you said, everybody's ship floats up. It's an awareness problem, and if we solve the awareness problem, there's going to be so many patients that need help frankly, I'm a little worried we won't be able to treat them all. But we'll to mix
We'll
my
figure out a
cliche,
way.
we'll burn that bridge when we get to it. I like to mix my cliches, but and here's why we should be involved too. Dentists see their patients more often than the physicians. We know our patients better. We know what they do for a living. We interact with them more than the medical community. And in the last 30 or 40 years, this has been the medical model. If we suspected 10 patients that have sleep disorder breathing, and we think maybe they have apnea, and maybe we're not even that good at suspecting, but let's assume we suspect the right people, we're going to refer them from the medical community to go get an in-lab test, is what's been going on for many, many years. And by Rich and my assessment, about half of them will go. And I think we're being really generous there, because I think it's even probably less than that. Most of them will have apnea, because we're not going to do tests on patients that don't have high risk. And if you do a good job screening, like we're going to teach you in a few moments, most patients that we screen that are high risk will have apnea. Most people out of that, about maybe half will wear their CPAP. But how many will actually wear it every night, all night long? Maybe one. And if you don't agree with our numbers, put your own numbers in here. But we're nowhere near 50% or 60, 70, 80% success rates with this. And here's where the dental model comes in, Rich. I mean, as you
Yeah, we said, let's take the same 10 patients, and instead of referring them for a sleep in-lab sleep study, we click a button in DS3, for example, and we have a home sleep test that can do this. So we get a lot more patients to do that. We get almost everyone. Now there is a caveat there. They gotta have their insurance cover it, and we understand all that stuff. But these companies that we work with are very good at that. So we've done a good job of screening, like we're going to teach you tonight. We confirm diagnosis in most of those patients. How many of them will wear a dental device that we make it for? Most of them will. And how many do we treat effectively? Yeah, there'll be a few that we can't treat. And even if we cut our numbers in half, we thought, okay, well, only four will wear it, and half of them, we're still as good or better than CPAP. And that's what we want to see, you all to see. There is a medical model out there that is simply not working.
right.
And
And
as dentists, we can affect some change in that. How do we do that? We start with screening our patients, and then we walk them down the path toward testing them. So let's talk about those two things.
Absolutely. So when it comes to dental sleep therapy, we're going to concentrate on the first two today. But what we'd like to mention is it's just steps, it's pieces to a puzzle, and there's nothing really that complicated about it. And if you're efficient and you have good systems like DS3, you can do this as a dentist in less than an hour time of yours, 45 minutes or less. Most of our offices who are using DS3 systems can do it in that. I know Rich and I personally spend closer to 30 minutes a patient, because we have good team members and we've been doing it a long time. But when I first started doing this, it took me a couple hours just per patient, between all the looking through the chart and so forth. So again, if you're interested in looking at a DS3, just type in free trial and we'll show you how we can be more efficient. And we're going to concentrate on these first two steps, understanding that there's really not that much to dental sleep. There's just a lot of parts, and if you get one of these pieces of the chain and they're broken, it's just not going to succeed. We're talking about two of the pillars today for what we consider for successful dental sleep medicine. We will be talking about the other two in later webinars, but if you have a system, accountability, and a plan for each of these pillars, you will succeed to whatever level you want in dental sleep medicine in your practice. And really, the screening probably is one of the easiest ones to do. It starts by having a plan and understanding how to look at your patients. And Rich, I
Yeah,
like this slide you made. This, I mean, we shouldn't be doing this just for the money. I hope we're treating our patients because we like what we're doing and we're helping people. But making money is an important part of running a business. We owe it to ourselves and our employees to make money. And if we're not screening, you're losing money, right? I mean, how many patients uh, in an average practice have obstructive sleep apnea that don't know it or aren't being currently treated?
well, go back to that big red pie you had there, guy. So we're
Yeah,
looking at 30 million people, and or conservatively 20% of the adult population. And if you got 1,000 patients in your practice, at least a couple hundred of them have sleep apnea and don't know it. So that's why we talk about the lowest hanging fruit. So we're going to start screening these patients, and we start right in our own practice. And how do you do that? You sell them the case, right? You tell them, oh, how bad surgery is. You don't want to wear CPAP and all that other stuff. No, we don't have enough information. We don't even know if they have sleep apnea yet. We're
right.
just trying to figure out. You walk in there and you're a hygienist. You're going to teach them how to do this and what to do. So, as somebody understands what the problem is and how it's affecting their life, then they start to ask, oh my gosh, what do I do about this? How do I find out if I have it? And that's kind of the idea of screening patients in the first place.
I like what you said there too, Rich. When they start asking you questions about it, then you know you've done a good job of communicating. I think people who've heard me speak before have talked about what I learned from Pete Dawson many years ago. He said, Guy, if you keep in mind everybody wants a healthy mouth, that it makes everything easier. No one really wants to have an unhealthy mouth, and no one really if you take what he said and put it towards sleep apnea, no reasonable person wants this stuff. No one wants to have all that things that were listed: GERD to impotence to death to cancer to heart attacks. No one wants that. So we just have to. I don't like the word educate, because what we have to do is let them discover that they're at risk for this and have them ask us questions. And once they're aware of it, it's pretty obvious that most people don't want to have this. And this may be the most important slide that we put up on the screen. I think if you just look.
Certainly is for the screening side of things, right? Because
Correct.
that's what we're talking about now, one of those pillars of screening. And you look at everybody in your practice, you review medical history on, and your hygienist, you've taught them how to do that. And you just look at all of these things. Somebody has high blood pressure and they snore and they have diabetes. You're looking at 80% chance that they have sleep apnea. So keep this in mind as you do your medical histories and you look at patients.
Yeah, what we'll talk about here is we're going to break down the steps of screening, and one part of that is you need to have yourself, if you're the dentist, or a team member or team members who understand this page right here. They have to understand, believe it, and realize how important this is. And they need to be able to converse with the patients about why they're at risk for having an airway problem. And we can, if you don't understand the facts here, it's a lot harder to converse. So I know when I first started, I printed these out, and I just had them in all my rooms, and I just wanted to keep all this stuff in mind as I was talking to my patients, and I would look for these red flags in your patients. And it's, you get one red flag, well, it's a little worrisome, but you start getting 1, 2, 3, 4 red flags on your patients, it's pretty obvious that we need to have a discussion with them. So we've got a few on the screen here. I think we're going to go through the red flags fairly quickly, and then we're going to give you a system so that you don't have to do it the way that I did it and Rich and I did it originally, where we just had this stuff in our head and go, oh, I remember they have high blood pressure. Maybe I should be worried about airway problems. We'll show you a little bit quicker system, but I think understanding the red flags first is good. And this is a pretty big one here. Is that headaches aren't all dentists don't. I think almost every questionnaire that I see from a dental office has headaches on their questionnaire.
Yeah, and what are we taught in dental school still to this day? Well, make them a night guard, make them a
Yep.
splint. Some people need night guards, some people need splints. But you have to understand that a lot of headaches are related to oxygen issues and oxygen drops, which are related to airway. So you look at cluster headaches, dull morning headaches, migraines. All of these have a direct link to sleep disordered breathing. So as we think about this in headaches, we want a different light bulb to go off in your brain. It's not just a night guard anymore. It's hey, let's talk about getting you a sleep test. Just like you said, Guy, this is all part of that screening process. Remember, we're looking for things. We see this erosion on the back of the teeth. Man, that's a bad case of reflux. But
Right.
we do see it, and we don't want you to think, man, I get to do crowns on all those teeth. Um, it, do the crowns and then put a mandibular repositioning device in them, because you're not treating, the crowns are not treating the cause of the disease. And a big cause of GERD is the diaphragm trying to breathe and trying to push up, but my airway's closed, so I'm pushing this acid up.
Absolutely. And that's what we call a red flag again. Everybody who has GERD doesn't have OSA, but it puts you twice as likely to have it. Measure your patient's necks. We give, at our seminars, we usually give out tape measures, and I think it's one of the best ways to segue into a conversation. You take the tape measure out, you measure your patient's neck. A man who
What do
has
they
over,
say, Guy?
yeah, they say, what are you doing that for?
Right,
Anytime you can
exactly.
get your patient to ask you a question, that's just golden. And so the patient says, what are you doing this for? Oh, well, thanks for asking. We're very committed to your health here at our office. And if it's the hygienist doing it, Dr. Yatros is very committed to your health. And we as dentists need to be evaluating your oral structures for the possibility that maybe you have an inadequate airway. The airway at times, at night in particular, in some people's becomes closed off enough to cause people problem, and people's neck size can directly be a clue to that. So that's why we're looking at it. And Mr. Jones, yours is 22, and we're worried about that because over 17 is concerned. So isn't that a nice way to have a conversation? It's a great segue. 17-inch for a man, 15-inch for a woman. Above those numbers, we're more and more worried. And there's no line in the sand for that. But those are the kind of the numbers that you should start thinking and discussing with your patient. Who's better about looking at this, Rich, than we as dentists? You think a physician would even know retrognathic from a prognathic patient readily?
I asked that guy today, do you know what retronathy is? And he said no. So that
Yeah,
physician I was, no, they don't pay much attention to that. But again, this is part of that education process of you educating the physicians. But as we do that, and you do that, you're just looking at these red flags. Here's the red flags. Guy's got his red flag on his slide up there.
yeah.
These are the things that you see now. Oh, caffeine. Oh gosh, yeah, exactly. How many cups of coffee do you drink? You drinking coffee in the afternoon. You drinking this and that. So, absolutely, that's another red flag.
You know anybody that looks like this, Rich? So, I snore, I have airway problems. I wear a dental device every night myself, and one of my issues is the long lower face height. We as dentists can recognize that as well. We're more prone to airway problems, maybe even a cause and effect we could get into on a different date. But long lower face height, think of red flag, and this is stuff that we want to get through your heads. And then scalloping of the tongue. I mean, what causes those marks? Those marks are caused by the tongue pushing on the teeth long enough to cause these indentations and frequent enough. So what is that muscle? That's the tongue is a muscle. What happens to that muscle when we're asleep at night? It becomes totally paralyzed at some points during REM sleep, and that tongue is no longer pushing on those teeth. It's very likely going to end up back in the airway. So there's a lot higher incidence of people with, I read something the other day, it was over 80% for people with scalloped tongue have at least some airway problem. So big red flag. We as dentists, we knew this was, I think it was on the national board test 100 years ago when I took it even. What about if you're doing your oral cancer exam, Rich? Do you see any difference here between these two while you're back there looking for oral cancer?
Well, you're looking. You might as well look at their airway too. You're looking at their tongue and their palate and their uvula and all that, their tonsil folds and pharyngeal grading and things like that. So that guy on the top, he's got a lot more crowded airway than that guy on the bottom. So if you combine these things, remember, the more red flags that you have with any given patient, the higher their risk assessment of having sleep disordered breathing. And what we're doing is we are going through these red flags with you. This is, as a dentist, you're going to see this all the time. People will walk in the door. You go, wow, that lady's retinopathic. She's obese. She opens her mouth. She's got a scalloped tongue. You see this huge uvula. The palate goes way back. We want you to be thinking about this as you do it.
Yeah, and I could even tell this patient, how long have you been snoring? Or let's ask the wife if it's a man, because I can about guarantee you this patient snores because that uvula didn't get that way overnight. And so those are the red flags. I see some questions are coming in. We're trying to answer them. I see some hands are raised. We can, at the end of if you came on a little bit late, we will take questions at the end and stay on as long as needed to get all your questions. So don't worry about that. But we've got a lot to get through before the end of the hour. Also, people that came on late, I see a few people typing in. If you want to come to one of those courses, again, $200 off the 2-day, 50 off the 1-day. Just type in course, or if you want the free trial, type that in. I see some of those coming in as well, and we'll keep trying to answer questions as we go along. I think the biggest challenge, Rich, when it came to screening and us learning how to do this, for many years, at least I think you did it as well, that we just had those red flags in our head, and after a while we would learn. We go, oh, after just talking, hey, you're susceptible to this, but we really didn't have a system for it. And so I could do it, but then I have to train my team members to do this, and it was hard to get it in their heads and just intuitively know who to ask the right questions to. And I think when you break down this system, if you have a system to identify the patients quickly, so in 5 minutes or less, we can say these people are at risk and these people aren't as much at risk. Some of them still might be, but we want to skim the ones off the top that are very high at risk. Then we need someone in our offices, either ourselves or a team member, or we recommend a sleep ambassador, a team member who's really the sleep guru in the practice, to discuss this with the patient to where the patient acknowledges, like Rich said earlier, that, hey, that they may be at risk and they understand that there's something going on here. And then we have to have a system to test them. We're going to get in that to a minute. And then later modules we'll talk about treating. But I think the biggest problem people make is they try to go from, oh, you're retinopathic, I bet you have apnea, you snore, let's make you a mandibular advancement device, and they don't go through the
You've
steps.
skipped a couple in between there. Because that
Absolutely.
acknowledge part, Guy, that's a big part of that is that slide you showed earlier where as people's awareness of the problem goes up, so does their willingness to treat it. So, and when you try to skip some of these steps, then it becomes a harder sell. If you understand the process and what's going through somebody's mind, and you're identifying these people and you're getting them to understand this disease process, the more they understand about it, the more willing they are to get tested and treated.
Right. And I'm not saying Rich and I think Rich is the one that started this a long time ago, but you'll hear us say you got to use your brains, and we can't do everything for you. But I can tell you, if you come up with a screening process, you'll get the majority of people, lots and lots and lots, hundreds of patients in your practice who need your help. And then we can still use our brains, and some of them that maybe don't identify at high risk on the screening process, we can also talk to them later and get them tested as well. But let's start with like you said, the low-hanging fruit. And when it comes to a screening process, what you want is a quick way to be done. Ideally, the patient can just do it with some questionnaires. And one thing I like about what we do is I like it when the patient's finished with this screening process that they go, oh, yeah, I failed this test, or I want it to prompt a conversation for them, not just fill this out and then turn it in and then let me throw a bunch of information at you. If the test itself can kind of elicit some conversation, it works real well. And the way we recommend doing that, the way we do it in DS3 at least, is we have a part of our software is an application that is intended to be used on tablets. And so when the patient comes in, the verbal skills we use for this are extremely important. So when the patient comes in, we don't just throw a tablet at them and say, hey, we want to see if you have apnea, fill this out. I mean, that's going to get you absolutely nowhere. We ask that our team members fill out the patient's name on the tablet, and then they hit next, and then they hand it to the patient. And when they hand it to the patient, they say, you know, Dr. Yatros will be with you in just a few moments, but while we're getting the room ready, we'd like to update your health history. There's some additional questions we'd like to update. Do you mind filling these out while we're getting the room ready for you? And while you're waiting, please give me a copy of your medical insurance card. Let me get it, and I'll take a copy of it, because some things covered in our office now are covered by medical insurance, and we want to have a copy on file. So most patients will readily give you their medical insurance card, and then they take the tablet. It's not a big deal. Act like you've done it before, and don't make the patient apprehensive like it's some big deal that we're looking for apnea.
I love what you said there, Guy. Act like you've done it before.
Yes,
Don't act like this the first time you've ever done this. Just act like this is just normal routine, and they're going to do that. And they just answered basically an Epworth sleepiness scale.
right.
How sleepy are they? If you haven't seen this, it's all over the internet. You can Google it. It's all there. There are 8 questions. You score from 0 to 3 on your likelihood that you would fall asleep in any one of these situations. Anything under about 8, 9, 10, somewhere in there we go, that's okay. A little bit of sleepiness is okay, but somewhere around 10, 11, 12, you get to where, you know what, you're sleepy. You're excessively sleepy during the day. And this puts you at risk for driving a car, getting in an accident, somebody who's a assembly line worker, those types of things. I saw a patient today, Guy. She said, I'm sitting there talking to my boss and I'm having trouble staying awake, while he's
Right.
talking to me. So some situations are more dangerous than others. But again, that this is part of the screener and the system that we're teaching you to use. That's the first part. What's after that?
Well, after we assess if they're sleepy, because one of the number one causes for excessive daytime sleepiness is airway problems. And again, we're using the word airway because we don't know if the patient has apnea. Let's don't give them a diagnosis that they may or may not have. So they hit the next button on the tablet, and there's just some questions that have a scoring that was developed by the American Academy of Sleep Medicine several years ago. And there's questions about snoring, about what amounts to periodic limb movements with their legs jerking, headaches, insomnia questions about falling or staying asleep, witness apneas. And so basically the patient just answers yes or no on these questions. And this particular page has its own built in into the software scoring that defines whether the person's at severe or low risk for sleep disorder breathing. And then they hit the next button again, and then we have some what we call comorbidities, and some of them are listed here on the page. Anything from hypertension to diabetes. I think this is an old slide. We have AFib on there these days too. But if you have hypertension, if you go back to those red flags, as much as 30 to 37% of patients, so I usually put it right in the middle, at least a third of them, depending on which study you look at, have obstructive sleep apnea. And my question to the dentist out there and the dental teams who are listening tonight, if you saw a lesion on someone's tongue that you were concerned about, or a lip, and there was a 1 out of 3 chance that it was carcinogenic, would you consider that high risk? Would you insist that patient, really seriously consider getting a biopsy and a diagnosis of that?
Of
I
course you
think
would.
I thought
Right.
you would. Right. So
Absolutely.
So the part I like about our system here too is so we've got 3 sections of assessed them. At the end of the day, when the patient hits the next button, it takes them about 5 minutes or less to fill it out. They have this graphic in front of it where it says there's severe risk. And what happens next is really important in the office. If the patient just says, what is this? And the front desk person has other people waiting there and they're trying to have a conversation and maybe they don't know what it means exactly. You need to have someone, a system and people or person that is accountable for discussing it. So it's fine to say when the patient brings it back up, hey, I don't know what this means. What am I severe risk for? Someone explain this to me. That the front desk person says, you know what, just take the tablet with you, go back to the hygiene room. Kelly will be with you in a minute, and Dr. Yatros will be in a minute. And whoever it is in your office is going to discuss it. Maybe it's your sleep ambassador. In my case, it would have been Brandy years ago. Brandy will be in to discuss those results with you in just a little while. And just let the patient hold on to it. If it's a doctor, the doctor can come in. And so at some point down the road in the appointment, whoever's going to discuss it comes in, and then they can just hit the view results button here. And when they do that, the results of the test are going to come up for the sleep ambassador or the dentist to discuss with the patient. And then here's where knowing those red flags and understanding it and understanding how significant this is becomes into play. And this is where verbal skills and confidence certainly comes into play, where they can go through each of those sections and explain to them about what their concerns are and why they're concerned about their airway. They can relate the high blood pressure and the diabetes and the odds and the sleepiness to this. And the whole goal there is to elicit a conversation, to get a conversation rather into with the patient where they're asking us questions back and forth to where they become engaged in this discussion.
Yeah, you said a couple of things there, Guy. I want to drive home. One, hang on to that tablet. Kelly's going to take you back in just a minute. Now that patient gets to look at that severe risk arrow,
Right.
and you can tell them you think they have sleep apnea. It doesn't mean anything, but if that computer does, it really means something. So, and the other thing was, what does this mean? You're getting patients to ask that, and within our system here, here's your cheat sheet. So
Right.
until you learn this, you got to act like you've done it 100 times before. Well,
Yes.
you're at severe risk. You know, we love that fake it till you make it saying, well, here's the reasons. It's right here, and you just read them off.
Yes.
And here are the health symptoms and stuff like that. And what happens next, Guy? They usually go, well, my gosh, what do I do about this?
Right. And if they do, so at this point, what we hope the patient will say is exactly that. And then you say, well, we need to get a test just basically to see if you're breathing normally at night. We hope that your airway is staying open, but it may be becoming restricted enough at night to help contribute to the high blood pressure, diabetes, sleepiness, and snoring that you have. Even explaining the snoring as to the fact that snoring is snoring is a sign of a poor airway. So let's just measure that. There's two ways you can do that. You can go to the sleep lab and we can set you up an appointment. You can spend the night there. Or now we have a thing about the size of your iPhone that you can wear at home depending on which one we use. And you wear it at home. It measures your breathing. We have doctors who review those results. And we'll be able to tell from that whether you're having a nice open airway or not. Which one would you prefer? Okay, and that's the key. We don't say, would you please go get a test? If you see a physician and they think you're at risk for something as severe as sleep apnea, they usually don't ask your permission. They say, we're concerned. It looks
Hey,
like you're at risk.
you need a blood test. We need to
Go
check.
get it done.
Go get it.
They,
Exactly.
they assume you're going to do it. And if you'll take that mental position and that confidence, and you give them the option between home sleep tests and PSGs, these patients absolutely will go. Rich and I can come into any of your offices and get literally every patient who's at risk tested because we are confident in it, and we really believe it. We've seen patients die. We understand how significant this is, but we also understand it takes some getting used to. And for patients, or I'm sorry, for dentist offices that have cone beam technology, one of the uses that we're seeing now, and it's kind of like the intraoral camera when it came along, that you talk to the patient, their tooth's all broken, but they just can't see it, and then you showed them that picture. Wow, then they agreed to doing this. One of the uses that we're really seeing for this, if you decide you're going to get a CBCT, think about getting one big enough to capture the airway and the other structures that you need. And we'll talk about this more, obviously, next time. But it can certainly be used to show a picture of the airway and say, this is the best your airway ever gets, Mr. Jones, because you're awake. When you're asleep, it's going to get way more narrow. And it can be the catalyst to show from a big open airway, you can show them a small airway, and we can talk to them about the minimal sizes of airway. And again, we'll get into this more in the next webinar about how those verbal skills can help us to get the patient tested. The bottom line is we just want to get these patients tested. We need to identify them. We need to talk to them until they understand. And I don't mean yell at them to go get a test. I mean have a conversation two ways where we're discussing why they're at risk for airway problems. And by all means, I do not agree, and I know some people that teach this think you should use the word apnea to scare people, but I don't think any of us would tell patients, I think you have cancer, until we knew they did. I think we don't use the word apnea until we have a diagnosis, in my opinion.
That's a good point. And the other thing, Guy, I want to add to that, it was very good, thank you, is what you have done with this system is you have screened somebody and you have started the education process, which does what? It makes them aware of what's going on,
Right.
and it gets their attention. That they now acknowledge that there is a serious disease process here that I very well may have. So, but again, we're not talking about treatment yet. We don't know if you even have the disease. Let's just go through the screener here. You express your concern. I'm concerned about you. We like healthy patients. You know that everything we do in our office here is we care. Oh, I know, Dr. Yatros, you care about me. I know that. So don't put the cart before the horse. Don't talk too much. But have a system for where you go now from you've
Right.
screened a patient. They are at high to severe risk, that you've done some education, they acknowledge that they have a problem, and now we talk about what happened next. And you have to have a plan for how you get them tested.
Absolutely. The last thing you want to do is do the hard work. The hard work is, the screening's not that hard, but we can get you through that. But the hard work, honestly, is the acknowledgement. And then the patient says, yes, I want one of those home sleep tests. And then you go, oh, okay, didn't we get one of those last year somewhere?
Where did they get that,
Hey,
Susan?
hang on a
Hey,
second. Yeah,
hey,
yeah,
who do we have?
yeah. Is there
It all
Acme
falls
Dental?
apart.
Yeah, it falls
Think
apart there.
think back to that chain you put up there, guy. And
Yeah,
they're moving parts. It's not that complicated, but if
right.
you don't have a plan, that chain is going to break and it's going to fall apart. So
You
what's the
gotta
plan,
have a
guy?
plan. So, well, let's talk about what we're looking for sleep apnea. Kind of like we did with the screening, we gave you the red flags first, then we gave you a system. Let's talk about how we get a diagnosis of OSA, and then we'll show you some systems for doing that, and hopefully we finish right on the hour. What are we looking for? We are looking for airflow. It's just that simple. We're looking to see if people are breathing at night. And you can see on the left side of your screen a big open airway, and as you can see as we go further to the right, there's a narrowing of the airway. And if we measure that with nasal cannulas that measure pressures, usually how it's done, we see nice breath on the left, in and out. As we start getting resistance, this line widens out and we get a flattening of the airway signal. So what's an apnea? An apnea, we're breathing. Those are each individual breaths you're seeing there on your screen. Nice breathing. And then an apnea is you're breathing and there's a flat line. It's no breath. And it's just pretty simple when you think about it. It's not that complicated. So we need some sort of a technology to measure that, which we will talk about in a minute. So people get apneas throughout the night, and we define them as 10 seconds or longer without breathing. So what is a hypopnea? So hypo meaning less, pnea meaning breath, so less breath, not without breath. So what does that look like, Rich? You want to explain that, or you
Yeah,
want me
so
to?
we've got the apneas where our airway closes down all the way. And a hypopnea is where our airway closes down partially. Think about a straw. We're going to drink a big, thick milkshake through a straw. If we got a nice milkshake in a cheap straw, as you suck on that straw, the sides of the trying to get that ice cream through, they cave in. We call that compliance of the airway. So a hypopnea is the airway not closing down all the way, but it's closing down part of the way. So we get less air moving through. Usually it's accompanied with snoring. Now that same thing happens for 10 seconds or more with a 3% drop in oxygen saturation, then boom, we call that a hypopnea. So now we have apneas and we have hypopneas.
Yeah, and they look real pretty on these screens if you have your own recorders or you spend time in the sleep lab. And we'll, again, talk to you about specifically how you do this in just a few moments. But understanding the concept, we're watching them breathe, we're looking at their oxygen, and then one other thing we're going to look at is whether or not they're trying to breathe or not. There are belts typically that go on the patient during a sleep test. So most sleep tests, and if you can see it on your screen, it says chest and abdomen. These are effort belts, and we're trying to breathe. But here we're not trying to breathe and we're not breathing. So it's assumed at that point that we're not really having an apneic event due to an obstruction. We're having an apneic event due to us not trying to breathe, and we call those central events. So there's obstructive apnea, central apnea. Don't spend a whole lot of your evening worrying about it because most apneas that you're going to run into are obstructive in nature.
Yeah, 97 to 98% of them
Yes.
are.
So for most
True
intensive
central sleep apnea is very rare.
rare. So your definitions, just to make sure we're all on the same page, is apnea, quit breathing for 10 seconds, hypopnea, a decrease for 10 seconds or longer with oxygen desaturations, which you can define those percentages differently than 3% or 4%, depending on who it is, but it has to have a decrease and an oxygen desaturation. And we actually define snoring. Now, some patients just say they just have snoring. They don't have apnea, but snoring, when a patient tells me, well, I just snore. Oh, well, good. At least you understand you have an airway problem. we're on the same page. Aren't you concerned? Because snoring in and of itself is a concern. And then we also kind of look to see throughout the night as we're measuring. These sleep tests will talk about measure other things, but one important thing is the oxygen levels, how long they stay down and below the 90 range. And in particular, the lowest that it went all night is called the LSAT, or the O2 nadir. So there's some quick definitions for you. Again, I don't mean to be rushing through it, but we want to get on to how you do this in your practice. We take that information, you take the apneas plus the hypopneas, and if you had, and you divide them by how long you slept. So if you had 50 apneas and 50 hypopneas and you slept a long time, 10 hours, your AHI would be 10, because you just take 50 plus 50 divided by 10 is 100, divided by 10 is 10. So about 10 an hour. So this is how many per hour airway constrictions a patient has. So there's your quick down and dirty definitions, but I think this is the important part, is how do we define this? I thought when I first got into this, Rich, man, if you quit breathing 4 times an hour, that's probably significant. That's probably severe apnea. And if I teach this, I ask that question, a lot of people are on the same page. I think these are pretty set these days. Some people use 10 here, but you agree with these numbers I'm going to put on the screen here, Rich?
Yeah, so we look at, and I've always kind of had a issue guy with mild, moderate, and severe sleep apnea
I
because
don't like the words.
we don't call mild cancer. I think we should call this stage 1, stage 2, and stage 3, something like that.
We
And
should
you
have a
can't,
4 and 5 too.
yeah, exactly. So you can have, but again, you got to draw the line somewhere. You got to put numbers up there, and you got to do that. So somebody says, "Oh, I had an AHI of 12." What does that mean? Well, here's your little schedule here. We have mild 5 to 15, moderate 15 to 30, and severe greater than 30. So that gives us an idea of where they are in that disease process. Well, what does that mean? And this is where your education comes in, and you do that. So most people will decide, at some point on what they want to do about it.
Yeah, and I think arbitrary may be a little strong, but I think I put this up here for you to understand. This is not an exact science. There was not a study that said a 10-second apnea is bad for you and a 9 you're going to live forever. So that's why they defined it as 10 seconds, and that 15 some magic number to put you in moderate. They're just numbers that were based on convenience and some science behind it, but let's don't get too caught up in it. If we just are trying to get more air, more better. Less air, not as good. And we got to try to define that somehow, and let's don't get too caught up in the numbers. And let's don't get too caught up in are they central or obstructive? There's mixed events that are kind of obstructive and central together. Most of the things that you're going to run into, most of the apneas rather, are going to be obstructive in nature. So let's get to the testing. There's really 2 types of testing that we do. One is to see if the patient actually has apnea. That's what we call a diagnostic or baseline test. And then we have tests to actually crank up the CPAP, and we call that CPAP titration, to where we adjust the pressure on the CPAP to get the airways open as we can, and then the technologists from the DME company, the CPAP company, will know how high to turn on the pressure and set that for the patient. We can also adjust our dental devices based on diagnostics, which are great. And then there's split night tests. So those are the 3 type tests you should be aware of as far as why we're doing diagnostic or to adjust a CPAP or dental device. And sometimes we combine those. Now the part I think that we're going to get to where we do this. And
we right now in this process, we're talking about a diagnostic test. We have screened our patient. We've gotten them to acknowledge that they have a problem. They say, holy cow, what do we do about this? Well, here's our options. You can go into a lab, a brick and mortar building, the local sleep lab, or you can have a home sleep test. And I love what you said before, Guy, when you said, well, which one would you prefer, the in-lab or the home sleep test? We're giving them the choices, the only 2 choices that we want them to choose. We're not saying, we're not asking, well, do you want to get a sleep test?
Yeah, I mean, and again,
no, I don't.
If you went to the physician, they wouldn't ask you the question. They would tell you, hey, you're at risk for colon cancer because your dad died of colon cancer. You need to schedule the colonoscopy. That's what they told me, and so what do? I went and scheduled that. You just do, the physicians don't really, they assume you want to live and that you'll do what's in your best interest, and there's not a whole lot of discussion. We'll go into these three types of home sleep tests a little bit more in a second, but for a home sleep test, there's three ways of doing that. But let's just kind of talk about the difference and contrast the in-lab or the polysomnogram versus the home sleep test, so that everyone's educated, at least cursory educated on what's going on. Here's what it was for many years. This is the standard of care. I mean, it looks like a lot of fun to me, doesn't it to you, Rich? Let's sign me up.
Yeah, you're gonna hook up 50 wires and you're gonna videotape me and hey, by the way, have a good night's rest.
Yeah,
It's an imperfect science. It absolutely is.
no
But
matter
when we
how we
do
do
that, yeah, no matter how we do it, but we get a lot of information from an in-lab test because we have more leads hooked up and you have technicians there that are doing it. You have all of these things. We get to see all these muscles move in the eyes and EEGs, and we can tell what sleep stage you're in and all that other kind of stuff. So we get I know you say this a lot, Gaia, an in-lab test is a more accurate
like it's coming
test.
up. It's
Oh, it's
coming up.
coming up.
Don't
Okay.
don't don't tip the hand yet. So
Okay. All
it's
right.
coming up. But yes, I want you to think about that. The in-lab test has more data, and the main thing we can really tell is if you're sleeping or not. It does sleep staging. Most home tests don't. They do also measure EKG and muscles and so forth. And until around 2007, 2008, there was no choice in this country. There was in other countries. You only could get a diagnosis from a PSG.
Or an
And now,
in-lab
I'm
test.
sorry, yeah, for in-lab PSG. And now that there's a debate because you can use home sleep test as of 2008. And one thing we'll drive home is it may, we're going to debate, or you can debate after we get off this webinar, which one's a better test, and we'll give you the cue to what Rich said in a moment, but really may not be our choice. Insurances are starting to dictate this. This is one Medicare insurance coverage. I forget which state it was in, but Medicare decided that we're going to quit doing PSGs and only do home sleep tests. Now, if the home sleep tests have problems, they may do a PSG as a follow-up, but as a baseline diagnostic test, here it is that the home sleep test is the only thing that's covered. Look what happened. Uh, look what happened with the testing. More home tests, sleep labs started going out of business as we started changing insurance carriers. Who made that decision?
It wasn't me.
It
But
was the insurance
we we
insurance
fo-
company.
we follow the dollar, right? I mean, that's a lot of this stuff that we're doing. So, and I want to make a point too that it's really not our call all the time on what kind of test that the patient gets. We want them to get tested. We've screened them. We want them to get tested. And there are these home sleep tests that you can do, and we work with multiple home sleep testing companies. You can give us a call. We'll love to show you a DS3. We just click a buttons, and some of this stuff happens. Guys in Florida, I'm in Texas. We do this all the time.
Right.
There are very few states that say, I think New Jersey is the only one I can think of right now where they don't want a dentist ordering a sleep test. So there's a little bit of a turf war going on here right now. But right now you have to check with your state board. But as far as we know, we are doing this in Florida and Texas all the time. But
And the other dentists we train and taught to do it all over the country as well. And the bottom line is that a home sleep test is a good test, but it does have to be interpreted by a physician, ideally a board certified sleep physician, and that's true in all states. Whether we as dentists can order them or not, I think I'll discuss in just a minute more in more detail. I'd like to mention too that there's been studies that show home sleep test at the exact same time as the PSG. If you look at the solid line and the dots are the home sleep test, we're getting very similar data. So the data is the same. And the question that Rich started to come to a moment ago is, which is more accurate? Is if the PSG, you spend the night in the sleep lab, you've got all these extra leads, we can tell if you're asleep. If the leads come off, we can put them back on. So in a way, we may think they're more accurate, but at home, you sleep better. It's in your own home. You get to deeper sleep where we're more prone to apnea. So what Rich was getting ready to say is that a PSG is more accurate test of a less accurate night's sleep. We have more data, but we're not sleeping as well when we're all wired up like the picture showed you. And a home sleep test is a less accurate test of a more accurate night's sleep. So it really just kind of comes down to what trumps what. bottom line is insurances are maybe making this decision for us, and which is strongly going in the home sleep testing direction. My personal bias is I honestly believe a home sleep test, when everything is considered, gives us a better idea of what that person's airway is doing on any given night. And it's less expensive, and more people will go to it as well. So that's my personal opinion on it. But you can make your own decisions. Still there, Rich?
I
I
am
talked
here.
to
My
the,
phone was ringing in the other room, so I muted myself for a second. But no, I agree completely. There's you know what I hear a lot, Guy, is, well, which one will my insurance cover?
right.
You know, I say, well, would you want the in-lab test or you want the home sleep test? Well, which one will my insurance cover? Well, Cindy here is our sleep ambassador. She's going to help you figure that out. We've already copied your medical insurance card, right?
Right.
Guy, because that's what you said earlier.
We've already got that done.
That was
We'll
part of
screen
the
it.
verbiage, yeah, that what we're doing in the office. So you get to see how this system that we're talking about doing, because we've done it 10,000 times, has has all of the bases covered, and we're connecting all of the dots as we do this, and it just makes it easier. You don't have to reinvent the wheel here, but you can. You know, there's this debate going on about who can order a sleep test and all this other stuff. So again, check with your state board, but I'm doing this in Texas all the time. Guys doing it in Florida all the time. A lot of dentists are doing it. So we want to work with physicians and we want to collaborate, but we want to get them down the right path too. So let's keep going, Guy. We're doing good. We just got a
Yeah,
few
so let me just
slides.
emphasize this slide. If you want to use home sleep testing, one way is you can own your own device. You've got to buy it, you've got to hook it up, you've got to maintain it. But you can do that, hand it to a patient, get a diagnosis by sending that data to a physician, or working with a local physician who makes the diagnosis and interpretation. The other, on the number 3, we'll jump down to, is you can work with a physician in your area. You can refer them to them, and they can dispense the test. You can do that, of course, in any state. What we're talking about here are companies, we work with quite a few of them, that basically we refer the patient to. The patient is sent the sleep test to their house. The patient wears the sleep test for 1 or 2 nights. They send it back. Those companies have board certified sleep physicians who interpret it, make a diagnosis on the patient, and they send a copy of that to us. They bill the patient directly, so there's no cost to the dentist. It's what patients are used to. It's like going down to get a blood work done at the lab, and we do that all across the country in many states. There are some states that maybe the dental board has said that's not the preferred way of doing it, but we do it in many of our states throughout. And in DS3, we do that as simply as hitting a button. We actually can order that right through our software. It communicates with these companies. If you want to know about the companies, contact us. We'll hook you up with several of the companies that we work with who do this. And in my office, Rich, that's, when it's up to me, that's the way I prefer to do this all day long. If I can click a button, my patient gets this thing at home, and I get it back. Now, once I get that information, we do work with the primary care. We send it to them. We work with them to get a letter of medical necessity and prescription, which we will talk about in Module 4 about insurance, about the 4th pillar. So we're not trying to exclude the medical community. We're just trying
No,
to jumpstart this
absolutely not.
process and get it done, because it hasn't happened up until now. And its patients need our help, and people are having inferior lives, and they're actually dying because of lack of
I've had to
diagnosis.
answer that question many times, Guy. The
Yeah,
sleep physician says, well, what are you guys doing the sleep test? Well, I
yeah.
guess we're doing your job. Patient's sleepy, tired, he's got diabetes, he's got high blood pressure. Man, I thought you would have ordered this already. So,
Yeah,
and again,
well,
yes,
I might say it a little bit more diplomatically than that, but you're right. You're absolutely
I'm
right.
kidding.
And
I'm kidding.
if you keep the patient's best interest in mind, we're just trying to help this patient. And like, again, it's a great system. So we get a patient's tested, then we work with the physicians. We're going to finish up the next 2 minutes with just kind of a real quick what happens after that, kind of a sneak preview of modules to do with treating and billing. Once we get our patients the device, we're going to get them to wear it comfortably. Most patients will. We'll look for improvements in their subjective concerns, such as snoring, sleepiness. And then we're going to follow up with another sleep test, which we use the same company that we did the first test with. We just order another test with them to do a follow-up sleep testing. So
And
it's
it's
kind of a
now a
glimpse.
titration sleep study with their dental device in play.
Absolutely. And I'll put everything on the screen for time's sake because I think we're going to get finished on time here. But after we deliver the device, we're going to look at their symptoms. If they're good, we're going to get a sleep test. If they're not, we're going to move the device more forward and we'll check them again. And then eventually we'll do the test, and hopefully that's good. If not, we may have to do another test. But we have ways of really doing more than one night test and dialing this in quite well. And then we want to see our patients about 6 months after the first time we treat them, and then about 12 months thereafter. So it's just about that simple. And it's just having a plan for the 4 pillars that we talked about over and over again. Hopefully, I mean, it was just an hour. You want to come to one of our courses again, we're giving 200 off for the 2 days, 50 off the just one day. Just type in course in the city if you know the city, and we'll get you in because I know we've thrown a lot of information. We will get into treatment and billing later on. But the next meeting we have is on CBCT. Here's our contact information. Try us out for a free trial if you want. We're not going to be pushy. I think you'll get more value out of it than you can imagine. Just seeing what we can help you be more efficient and as well as be more educated if you're new to this. We can really, it's like getting a golf pro at the beginning instead of trying to play golf for 5 years and learning a bunch of bad habits. Let us help you with all the things that we've gone through before. And just to finish right on time here, real quick, the Dental Sleep Insider free online magazine and that we do. Rich and I do articles. Rich usually writes one. I do a video. We have great pragmatic information, and just sign up. It's free. DentalSleepInsider.com, and we'll be happy to put you on our mailing list for that. Our next webinar, again, is coming up on CBCT, so on July 26th, so that's going to be fun and exciting. And here's the list of the courses again for anybody who wants to sign up. If you don't, if you call us tomorrow, we're still welcome to register, but if you know tonight, you can save a little bit of money on that as well. So I'll put those back up in a minute if someone wants, but to remind everybody too about the symposium, there's the dates on that. That's going to be real exciting. John Remmers, Keith Thornton, in addition to Rich and I, and Aaron Elliott and Stacy Lehman, we're adding more people than that. Then Clearwater Beach at the Hilton Resort in February, so it should be a great time as well. Man, we got through all that, Rich, on time. Let's see where we are. There's our contact.
Fast, man, I'm telling you.
I made up for some lost ground there, so sorry for taking over there for a minute, but I want it to be.
No, thank you.
We pride ourselves on running on time and being organized. That's what we do. So we're happy to hang out, answer questions. I know, Rich, you've been answering some of these questions as we go. So where are we with the questions? Is if anybody wants.
Pretty good, I think.
If anybody wants to raise a hand or anything wants to be unmuted, I can verbally let you ask a question if you want, or are we good?
Yeah, we had a lot of good ones. I'll just address one. There was a little bit more of an advanced question, though. Dr. Levine had asked about, what are we going to miss some stuff with the home sleep test? What about upper airway resistance or periodic limb movements or something like that? And if you guys that are just getting into this don't really know what that means, but yeah, it's like Guy said, it's an imperfect system. I would, at the AADSM in Denver, there was a whole hour lecture about night-to-night variability. So the AHI can vary from 4, 6, 7, 8 events just night to night. So you could do a test one night, Guy, and have a AHI of 4, and you do it the next night and it's 10. And if you just did one test, that 4 falls below 5, and somebody says you don't have sleep apnea. But what if the patient's very sleepy? What if they have high blood pressure? What if all these other things? So what does that come in, Guy? You got to use your brain, right? So you got to use your brain with this stuff.
Yeah, and I'd add this too. Google a first night effect, Dr. Levine, and what that is they did studies on patients who did PSGs 2 nights in a row, and the apnea was substantially worse the second night than it was the first night because the patients just didn't sleep well the first night, and they're probably exhausted the second night because they didn't sleep well. And one of the home sleep testing companies that we've worked with over the years had done a lot of 3-night tests early on, and they found 4.9% of the patients that were mild to moderate on one night were severe on another. So that's almost 5%. So it isn't perfect, and yes, we're going to miss some things, but the protocol is if you think someone's at risk for sleep apnea and you test them with a home sleep test and it comes back negative, then they should have a PSG because maybe it missed something. So
Right.
that's where I feel.
That's what the Medicare guidelines actually recommend. So
Right.
again, this is where you collaborate with your physicians and you do some of this stuff. So we know most of you on here are newbies, and that's a little bit more advanced question, but we want to answer some of those as well too. But again, we are trying to screen people. We're trying to identify the low-hanging fruit in our practice. I mean, think about this. There are a lot of people out there that have this disease that don't know it. And I think as dentists, we owe it to our patients. We said it's the right thing to do, and we said it's meaningful work. And those are two really good reasons to do this. And by the way, you can make a living at it.
Yeah.
We have a DS3 member who got out of dental school, and he's never done a filling yet. He has
Yeah.
done nothing but sleep, right, for a couple years now. And this is a kid that just got out of school. So you can't make a living at it. And again, we're not doing it just for money. We're doing it because it's the right thing to do. But we hope that you've got something out of that. We do have a lot of courses. We do a lot of these all over the country all the time. You get to hear a guy do those, and he does a fantastic job. It's great to have your staff there as well. I want to bring up one more thing, Guy. We think about all these questions asked at the dental office, and there's 100 a day asked, but the dentist only gets asked like 9 or 10 of them. So that's why it's important to educate your staff as well. We think when you get your staff involved with this and you really see what they do, and the other thing's that sleep ambassador, isn't it, Guy? You get somebody who just takes the bull by the horns and really, really quarterbacks the whole process of screening and getting the sleep test ordered and managed and all that other kind of stuff. We really see those practices start to do a lot
That
of dental devices.
that is precisely how I got to where I am. I had a busy restorative practice, did a lot of prosthetics, loved my practice, but I liked doing sleep. And I wasn't taking off. And you and I met, and we tried to put systems together. And then I hired an individual. Her job and was to build the sleep practice, and she knew that her raises and where she was, and it was her job. And that one small investment of an employee, by the end of that first year, I was paying for her 4 times over. And that for my practice, it worked, and we've seen it work in dozens of other practices to get one person. That's not the only way to do it. You can divide these duties up and do it, but whoever's going to do it has to have time, and they need to be accountable, and they need to understand that it's part of their job to make them successful.
Well, you just kind of defined a system there, didn't you, Guy? You
Well,
you
that's
can
what we do.
you can divide it up, right? But everybody's got to have a job, and everybody's got to know who's doing what, and when, and all that other kind of stuff. And that's what we've tried to do for you, is to put together a system to do that. So
Right.
excellent.
Well,
Thank you, Guy, for putting all that stuff together. I don't see any more questions here.
Well, you've done such a
So
good job of you all have done such a good job of answering them. I appreciate it. And again, I'll put the one last. That's how you get a hold of us. If we can help you, that's what we do. If again you want to try us out, or if you just have a question, we'll field a call from you. We have a whole member support expert team that all they do is help dentists succeed at this. They answer questions from insurance billing to which devices to use to titration, and that's their sole purpose in life is to help dentists succeed. So if we can help you, that's where makes us feel like we've done something good, and we think about all the lives that that makes me happy, man. You think about not just our patients we've helped, all the dentists we've trained, hundreds and hundreds of dentists that use our system, and that we've saved lives by that, and we've helped lives, and it makes me feel like it was worth sacrificing a little bit of my time this evening with my family to hang out with you and everybody that's listening. So we appreciate you staying on and listening, and hopefully a lot of you stay until the end, and we appreciate that as well. So if we can help you, let us know.
so get out there and start screening, man, and identify these people, and let's get them sleep tested and sleeping better and feeling better and living longer. So thank you, guys. Have a good
All
evening.
right. Have a good night. Bye-bye.